Hello, my name is Dr. Raja Adnan Ahmed, and I am a psychiatrist, and I work in UK. And with me, I got Dr. Rinnie Brar, who's IMG from India, and we're recording this video for the career guidance session, especially in obs and gynae, because Dr. Brar has just got her ST3 job in obs and gynae, and she is an experienced obs and gynae doctor from India. So a lot of people who ask us, if we are all overqualified for ST1 level, and if we already got experience in our home country, what can we do to get into the training program? So there are different level of training. I think this is important one because to understand, because then you can enter the stage of ST3 as well. So first, I'd like to thank Dr. Barada because they have to give us time, especially on a Sunday, and if you can take us through your journey as a doctor so far, I think that will be useful for the IMGs.
Hi, Dr. Raja. Thank you so much for having me here today. So, I started after graduating from medical school MBBS in 2015. I started MD, which is equal to MS or FCPS
Mm.
in Obs and Gynae. I did it for 3 years from 2015 to 2018. And then from 2018 to 21, I worked as a senior resident in the same institute. And then from 21 to about middle of 23, about the first bit of 2023, I worked as a consultant. And then I started working in the UK from last 31st of July 2023. I've been a senior clinical fellow in Obs and Gynae here in the UK now.
So how did you get your GMC registration? Was it through the route of PLAB?
Now, I did all parts of MRCOG and I used that to apply for GMC registration.
Okay, I think this is an important thing to note as well, because a lot of doctors, they think, for if you're a senior doctor, then you don't have to do PLAB. You can actually aim for the exams of the Royal College, and it's not just MRCOG, other exams like MRCP, MRCS that can help you gain the registration in UK. So when you came to UK, were you focused on getting training, or did you have this idea that I'll check Caesar pathway and training pathway both, or were you actually sure that you were going for training?
Even now, I'm a little bit confused whether
Mm.
I did the right thing or not, because lots of people tell me that you've got all this experience, you've worked as a consultant, you should just pursue the CSER pathway. But actually, one of my supervisors told me that sometimes, although CCT and CSER, they are considered equal, but there may be some bit of a bias towards favoring CCT candidates than CSER candidates when applying for consultant posts. And for that reason, I thought CCT would be better, and I applied for training program.
Mm.
That was
And
one
what
of
has,
my
sorry,
reasons.
I was going to ask you, what has been your experience so far in ops and gynae, working as the senior clinical fellow? Was it something that was meeting your expectation or not meeting your expectation? Because people have different ideas when they're moving countries.
Actually, I think I got very lucky. When I was interviewing for various posts, there were a couple of trusts that were seeking to employ registrars at ST6-7 level,
Mm.
but then they would ask that it's okay to start from SHO level. They would work for 6 months as an SHO level and then step up to ST3 to 5 for another 6 months and then gradually get on to ST6-7. But here at my trust, I started as a registrar from ST3 to 5 level.
Mm.
That is my post, but now they've seen me work, they've gained confidence, I worked hard. Now I actually get some clinics and experience of ST6-7 level as well. So I think if you work very hard and you show
Mm.
sincerity, you can get the experience that you want. It's not that they will limit you or they would subdue you. It's not like that.
And another worry surgeons especially have, that they feel that coming to UK they won't get the time in the theaters, and because it will be given to the trainees, or other consultants will be doing that. So do you think you get hands-on experience that much as you think as you were exposed to India? I think probably it's not as much as you were exposed to India, but enough to actually learn as a doctor.
So in obs and gynae, we know there are two parts, obs and gynae.
Mm.
Obstetrics, I think, is very heavy, even in the UK. I
Yeah.
sometimes I feel like I'm back home with the same kind of workload. So
Mm.
obs, I have no doubt, it's the exact same kind of experience as I had back home. You do independent cesareans. For PPH, even your consultant may be there, but you do procedures
Mm.
such as Buckley balloon insertion, but under consultant supervision. Once they gain confidence and once you have gotten your competencies signed off, then you can obviously progress in your surgical skills. And when we talk about gynae procedures such as laparoscopies or benign surgeries, I've actually they do post you in gynecological procedures as well. They are very short of
Mm,
registrars. It's not that you are limited in terms of your surgical experience. It all depends upon the dedication that you show. If you show that you are a diligent trainee or a diligent non-trainee, after my night shift, sometimes I used to just go and shadow my consultants,
mm,
that I'm very interested in this theater and I would just like to be here. I
mm,
did that for 2, 3 times. And the next time they said, you know what, Rini, come in and scrub in. And I
mhm,
got all my experience. And some laparoscopic surgeries that I wasn't signed off in India, in a very short span of time, I actually managed to get signed off in this country.
mm. That's very good. So if coming to the ST3 level, when you applied for the training position, what was the procedure? What was involved? What was the requirement at that stage?
So for ST3, first thing they look for is GMC registration. So either through PLAB pathway or through MRCOG pathway, you need to have GMC registration. Then they're looking at people who have clinical experience and hands-on skill experience
Mm,
to the level of an ST2 candidate here in the UK. So for that, they will get you to get an alternative competency form signed. It has procedures such as simple instrumental deliveries, cesarean sections, opening and closing abdomens during surgeries, or fetal scalp sampling if they've written a star that if your trust does fetal scalp blood sampling, some bit of experience in audit, publications, teaching. I think that's all that they list as basic criteria. Once you build your portfolio and once you start matching those skills, you are eligible to get long listed.
so in the minimal criteria, you said you need MRC OG as well, not the full exam.
Not the full MRCOG. Part
Okay.
1 MRCOG is
Okay.
needed.
Yeah, I
Part 2
think,
is
sorry,
necessary. Part 1 is necessary.
part one is essential criteria. So, and after you have been longlisted, so how, do they call everybody for interviews, or what is the next stage? How do they pick you for the candidate to come and attend the next part?
So total, the entire process is in 3 stages. First is long listing. For long listing, they would need 3 things. First is an application form in which they get your details, your particulars, your past experience,
Mm,
educational experience, some bit of teaching, audit, publication, academic achievements. And they also ask some white space questions in the application, like what made you choose obs and gynae as your career? Or what is your experience in obs and gynae so far? How do you feel that you would be able to match the minimum requirements for this post?
mm,
So these kind of white space questions. And how has your leadership experience in obs and gynae been? And do you think you have management experience equal to the post required? That's the first thing for long listing. The second thing is the alternative competencies form that you have to get signed by a consultant.
yeah.
The third thing is that they would ask you some questions which would be later on in the shortlisting stage, they would be used to check your shortlisting score.
Mm,
So those questions would be, they are in 6 domains. First domain is postgraduate medical qualifications, then teaching, audit, publication, presentations, and research. So these 3 things, once you have done, you apply for long listing.
yeah.
Once they think that, okay, this candidate matches the specified criteria, I would say about half of the candidates are not shortlisted, half are
Mm,
shortlisted. Then they shortlist you. And then they ask for proofs about all of those 6 domains.
yeah.
And they get you marks for every domain. Like if we talk about postgraduate medical qualifications, MD from India or FCPS or any other postgraduate obs and gynae degree is not counted. It was a surprise to me. I thought it would
Mm,
be counted. It is not
yeah.
counted. They count like diploma or certificates or postgraduate degrees like MSc in leadership, management, ultrasound, or quality improvement, research, these kind of things. The higher the level of degree, the more marks you have. For example, a diploma would get you 4 marks, a certificate course will get you 3 marks, a DNB will get you 0 marks, MD will get you 0 marks.
Mm,
That's domain 1. Then they ask about quality improvement projects. The higher the level that you have presented, like if you have presented a QIP at international level, you get the maximum marks. If you have presented at national level, some lower. If you've just presented at one presentation at a local level, you
mm,
get lower marks. I had presented 2 at a local level, so I got the medium kind of marks in that domain. Then you come to teaching. If you've got formal postgraduate teaching degree, the
mm,
highest level of marks. Otherwise, if you have made substantial contributions to a teaching program, like back home, sometimes we do help our
Yeah.
consultants making teaching programs. And if you have been the resident in charge or registrar in charge back home,
Mm.
you can get a letter back home that she has been significantly involved in the teaching program and has actually
Yeah.
made changes to the teaching program. Then you get 3 marks in it. Publications, higher the level of publication, like if you have done 2 publications in a PubMed indexed international journal, you get maximum marks. Non-PubMed indexed, your name is at the end of the authors, you get lower marks. Same is with research. If you have done an MD thesis or an FCPS thesis, you get more marks. If you've done PhD, you get 6 marks. And the last one was
Public.
presentation. If
Um,
you have presented at an international level, maximum marks, then national level, then regional level, local level. So I think it's very important for any candidate to start building up their portfolio as soon as possible. I think I did interview well, but I lost marks in shortlisting because I didn't have the time. I started in August and the applications opened in September. I didn't have a lot of time to build up my portfolio, and I
mm.
used all the evidence from back home to back my application. And after shortlisting, a total of score of 31 is there. Any candidate who has scored more than 10, they would be shortlisted based on the number of interview slots they have. And then they will ask you for evidence. They will check all the evidence, make sure that the marks you've given yourself
Yeah.
in the shortlisting self-assessment, they are correct. Then they will call you for interview, which is the last stage. Then the interview happens, which is in two kind of,
Mm.
it is divided into 2 segments. The first segment is labor ward prioritization or prioritization of patients, where they ask you clinical questions. They see if you prioritize right. Anybody who has got obs and gynae experience, I think they would be good in this segment. And the next segment is about yourself. It's called a
So sorry, the first segment you said, but labor ward prioritization, in that is it that they will give you a list of cases that which one you will go to first and which one you think is the more requiring more urgent um, input?
generally, yeah, they give you about 4 patients, and it's very easy to identify the top patient. Generally, they
Mm.
would be having massive PPH, they would be unstable or pulmonary embolism like that. So it's easy to prioritize the top one. And it's
Mm.
if you don't get your top priority right, you fail the entire interview. It is a must thing to have your top priority right. And then they see if you're delegating your colleagues accordingly. Like if
Yeah.
there is a preterm, you ask the neonatologist to go there. If there's somebody with anesthetic risk, you ask the anesthesiologist to go there. If somebody's low risk, you ask the midwife to go there.
Mm.
If there's some post-op, you ask your ST1 to go there. That kind of delegating of tasks. And then they ask you what tasks will you do for each of the patients.
Mm.
Like if there are 4 patients, then you start elaborating, like for one, I will do this, 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 this. Second, I will do this, and so forth. You've got a total of 15 minutes for both the stations. For the prioritization station, they give you 5 minutes before to read up your station and prepare mentally. For the portfolio station, they don't give you any preparatory time. It just starts bang on.
Mm.
So after preparing the first one, you read 5 minutes, then you give 15 minutes of non-stop talking. They don't interview, they
Mm.
don't stop you.
Mm.
There is no cross-questioning generally, unless you are on the right track. Unless you're on the wrong track, they stop you.
Mm.
Straight on, you keep on speaking for 15 minutes. Then you get a 5-minute break. Then you enter your next station, which is the portfolio station, where
Mm.
they ask you about your experience, what kind of person you are, and your team working skills, your leadership qualities. They ask you certain questions like, tell us about an experience where you made a mistake and how did you learn from it? Or tell us about your leadership experience or
Mm.
a scenario where you had to use your leadership skills.
Mm.
So it's very important that there are 4 questions in the portfolio domain, and total time is 15 minutes. So you have to really prepare for the interview, that you have to make your answer shorter, give all the information required, show that you are a good leader, really sell yourself in those 3 minutes per question. And then you get your scores and you get your feedback.
I
That's
think this
essential.
is very nicely explained. I think so. As I understand it, after long listing, you go through a short listing process of scores, and where you have the self-scoring criteria, you have to self-score yourself against the guidelines of different domains, and then you will be called for interview if you are scoring enough. And then the interview, you said there were two different stations. One was a clinical station to prioritize. The second was to talk about your portfolio and your achievements so far. And I think it's important to just note what things you've just said, that at the senior level, they like to see you lead. As a ST1 level, they may not have seen that much of management experience, but at this level, when they're checking for your prioritization, that your management skills and all that, they want to see that you are somebody who is developing as somebody who can leader. Um, because as a consultant, that is what the qualities they are looking for. I think that was very well explained. One question I had was that this form, the alternative competency form, just I'd like to say to the audience that this is similar to what other specialties are doing. So if you are coming to psychiatry, there are two different levels of training. You can either enter CT1 or ST4. So if you're entering CT1, you need what we call the CREST form, which is a foundation competency. And that form is the same form for all the specialties. So when you're applying for obs and gynae, medicine, GP, you need CREST form, the same form. But when you are applying for a higher training level, they don't require CREST form, but they require something called alternative competency form to say that you have got those years of experience. So there is a separate form. There's not a single alternative competency form which applies to all specialties. There will be different one for obs and gynae, there's a different one for psychiatry, different one for surgery, different one for IMT, medicine, all that. So you have to be careful which form are you filling, and you need to fill the most current form as well. This is another thing. IMG share the forms a lot. They put the website in emails, and then that might be an older version. So always look for the official website. So that alternative competency form, did you have any problems getting it filled? That was the one question. The second one was that do the person needs to be the consultant need to be in UK, or can that be signed back home from India if you were kind of new?
I didn't have any problems getting the form signed because it's a fairly straightforward form. There are
Mm,
6 or 7 procedures that they want you to do, that they want you to be competent at, and they are at the level of ST2, like simple cesarean sections. They don't want you to have done very complex
mm,
placenta accreta, percreta, not at all. Just simple cesarean sections, simple instrumental deliveries, simple perineal repairs. I think anybody who has 3 or 4 experience of obs and gynae will have those competencies, no doubt about it. Then there are certain things like leadership and management, which generally as IMGs we do lack in that.
mm,
For that, there was one segment of has this candidate participated in risk management. I had never participated in risk management back home. So I asked one of my consultants, who is the risk lead in my department, that can I help you in some way? And it would help you as well. I can review some cases and it will help me for my portfolio as well. He
mm,
was very kind. I reviewed a couple of cases, presented them in a meeting, and he signed off my risk management that yes, she has participated. So, and there was another thing. When you get these forms signed, it is not that like if the vacancies application opens in, let's say, 1st of September, then you have to have done everything before 1st of September.
yeah.
You can't look at the application form and say, okay, this is all that I need. Let's get it signed now. The deadline is in November. They've actually written that all of these things should be done by 1st of September.
Mm,
So even before the application start, you should have already built up your portfolio before even the applications open. And about the question of whether Indian consultants can sign or IMG consultants can sign, I'm not sure about that. But one of my friends had used one of our consultants back home in India was FRCOG, and he had signed for my colleague, and that
mm.
form was accepted. So I think it should be accepted as long as MRCOG or the Royal College is agreed
Yeah, I think it
that
should be written on the form somewhere in the form guidelines as well that who can sign. Normally, they make it very clear that if somebody is signing from abroad, what kind of qualification they need to have.
you have.
Uh, no, I think the other points are mentioning are very important because as IMGs, we know about something. We know about research. We know that we can send some manuscript to different journals and get those marks. But things like quality improvement, teaching experience, a lot of our IMGs do teach, and they will do a lot of other significant things in teaching as well. But then they won't know how to keep evidence for that. Then by the time the application is coming, they won't have evidence that they have done that. So I have on my YouTube channel, I have done video especially on those things, how to gather evidence. Quality improvement again, QIPs, audits. This is something in back in India and Pakistan, although quality improvement is happening, people are making changes to the department to improve, to implement guidelines, to improve the practice and all that. But they don't know what this is audit and this is QIP. They don't call it. They don't gather evidence around it. So I think this is important if you are coming to looking towards UK and are going to apply for training to understanding these criteria, these domain, and then start to incorporate that in your CVs, in your portfolio. Is there any advice around that? Is this something you struggle with?
I think very often we keep on doing things that our consultants ask you to. Like back home, I remember I did a lot of data gathering for one of my consultants, but I never got any evidence for it. If I had gotten, probably, then my research marks would have been higher.
Mm.
So I would say that whatever, anything that you're doing, keep on collecting your evidence. You have to get your all of your evidence before the application opens.
Yeah.
So you should be ready with all of your evidence before even they announce the dates. One should look back at the previous applications, previous job vacancies, and all of the criteria that are required, and start matching their portfolio straight away without even waiting for September, November, whenever the applications open. It's very important to be prepared in advance.
Mm.
I didn't, it was very hard for me. I was a newcomer and I didn't know a lot of these things.
Mm.
Only after now I can, okay, these were the mistakes that I had made, and it's important to learn from these mistakes. Keep everything prepared in advance. I
No,
had
I
a,
think that's sorry.
sorry, I had a certificate that I got later on after the applications opened. It was invalid. I couldn't use it.
Yeah, I think that is the thing. I have seen in even in psychiatry as well that people gathering evidence, trying to suddenly when they realize this is required, and they say, actually, I've done a lot of these things. I need to now go back to my consultant back home and ask for them. And sometime a year or two has passed, and they might find it difficult to communicate with them. It's easier when you're in front of your consultant. It's difficult when you're away. Then they might be, they might not acknowledge you so much. So think this is important. The other thing I was going to ask you, I mean, specifically for obs and gynae, I am not very familiar with the subspecialties you can do. You said the obstetrician and gynecology are two different things, but I'm pretty sure there are many more subspecialties as well. So in your part of your training, do you do rotations in different subspecialties, or do you have chance to develop? So if somebody wants to develop particular skill
Yeah.
in a specialty, do you get to choose that, or is that something that you automatically get?
So the entire training is divided into three parts.
Mm,
The first one, ST1 2, is the core, is the basic level,
yeah.
which if you're entering at ST3, you've already done it, those basic competencies. Then is the intermediate level of training, ST3 to 5, where you're posted in all the areas of obs and gynae, urogynecology, oncology, reproductive medicine, high risk medicine, fetal medicine, all of the different specialties. And you kind of try and assess, okay, this one I like, this I don't like, and you start to develop an interest. By ST5, you have the option of choosing, which is called as SITM, subspecialty interest modules. And in ST5, you can start your subspecialty interest modules. And in ST6 and 7, they are mainly focusing on your subspecialty, like what you want to like super specialize in or subspecialize in. We've got four main subspecializations, which are reproductive medicine, gyne-oncology, urogynecology, and maternal fetal medicine. Apart from this, you've got systems of literally everything, like early
Mm,
pregnancy care, robotic gynecology surgeries, or menopausal, contraception, sexual health. And you have to have at least two systems done in order to gain CCT. So now I will develop interest in any of the two systems that I want to do.
mm,
Want to subspecialize in, and then I will start to gain competencies, inform my rota coordinator that these are my systems, I need to rotate in these ones. And then they make you go into your kind of systems, and then you gain your competencies, and then you get your CCT after ST6 and 7, in which you focus on your subspecialties. ST3 to 5 is generally you do everything. 6,
mm.
7 becomes very specific to you.
And I think the last question around the exit exam. Do you have an exit exam? Because some specialties do, sometimes they don't. So
By
after MRCOG, is there an exit exam?
MRCOG is considered, I think, the exam. By ST2 level, you have to have at least part 1. By ST5 level, you should have completed your
Mm.
MRCOG part 2 and 3. And at the level of ST7, you just need to have your ARCP outcome, I think 6, and then you get your CCT. There is no exit exam as far as I am aware.
This is good, I think, because in medicine and some other specialties there is an exit exam. In psychiatry, luckily we just have the MRC psych. So then how do you get the fellowship then? This is the question people will ask because um, I think in psychiatry, this is the thing. People, when they look at the qualification, they think fellowship is the higher qualification. Although you can get the MRC psych and then you get the CCT, and based on that you become a consultant.
You become a
And in
consultant.
psychiatry, but the fellowship is not given by an exam. It's just given by experience. So when you have 10 years of experience, you can, and you show the college that you have made significant contribution, then you get the fellowship. So it's just that in psychiatry. Is it same in Ops and Gynae as well, that fellowship?
Are we talking about FRCOG?
Yeah, FRCOG. Yeah,
FRCOG is given after 12 years of MRCOG, and once you've made significant contributions to the field of
yeah.
ops and planning, then you get FRCOG. But there are different like fellowships that we have equivalent to the ones we have back in Asian countries, like fellowship in minimally invasive surgeries or fellowship in high risk obstetrics. It
Mm.
just you take a break from your training program, which is out of program OOP, and then you go apply for any of the fellowships. Like if I have a lot of interest in robotic surgery, but I feel like
Mm.
ST6 and 7, just 2 years, will be too less for me to develop all my competencies.
Yeah.
So I can actually take a break in
Mm.
ST6, go do the fellowship, gain a lot of experience, and then come back and join my training. It can help you in when you apply for your consultant posts. Like, okay, this guy actually has also done a fellowship apart from their SITM, so you are prioritized in the consultant posts. Those
Okay,
kind of
that's
fellowships are there.
yeah. I think those fellowships are there to add on your knowledge
I don't
around
know.
that. Yeah, that's pretty very good. No, thank you very much for joining and sharing your experience. That was very useful. I'm sure people going on at that level will be very it will be very helpful for them. The one question I have just remembered, I'm sure you must have seen or must have experienced people coming through MTI route as well, because there is an option gynae MTI scheme as well.
Yeah.
If you haven't gone through yourself, I don't expect you to know a lot about that. But have you seen people um coming through it, and what has been the experience, or is there any advice around that? Because people do ask questions around MTI.
I know about MTI. I read about it in the workforce report as well. I know that for MTI, you have to have at least part one,
Yeah,
and I think now they've included part two as well, that you have to have part two MRCOG, and then you apply for the MTI scheme. Essentially, you come and work in the UK for 2 years. And the aim is that you go back and apply the new knowledge that you learned in UK back home in your country. But it is said in the workforce report, it was actually written that about more than 50% of
yeah.
candidates actually continue to stay in the country. They either do a PLAB to get GMC registration or MRCOG, and then they continue either enter training programs or they enter Caesar and eventually become a consultant in the country.
Yeah, I think no. If you get it, what I understand is from MTI, it's same in psychiatry as well. They expect you to go back, but the GMC registration you're getting with MTI is actually is long standing. It's not that your GMC registration will also expire after 2 years. Your visa expires. So
Okay.
if you apply for other jobs and you get another job, then you can go on a different visa and then continue to work in UK. No, I think thank you very much for joining and I think giving the information. I think this is very useful for the international medical graduates, especially the ones who have experience in obstetrics and gynae and who like to come through that route. And this was very useful exercise.
Thank you so much for having me here, sir. And just one last bit I want to add is that a lot of my friends, my study partners that I prepared for the
Yeah,
interview, they are sometimes we as IMGs have this opinion that, oh my God, I am more than 35. Should I even start entering training?
yeah.
I have to tell that majority of the colleagues and friends that I studied with, they've got lots of experience and almost all of them got ST3 posts. So we should get that out of our minds that our age is this and our age is that. Just focus on what you want.
Yeah, for that I do advise IMGs to forget about the age. I know we have this bias. The first thing to consider, like legal, there are some legal binding things as well. So like for example in India, I'm not sure about India, but in Pakistan, when a job is advertised, sometimes they put an age there as well that the person needs to be under 30. So there's nothing like that in UK. There's no age bias. They cannot do that. That you can be a 50 or 60-year-old person. You'll still be, if you are meeting the
Yes,
criteria,
yeah,
then you
you
can
can work
apply.
as an individual as
Yeah.
well.
And then there is also no compulsory retirement age as well. This is another thing. So, like for example, in Pakistan, if you are working for a government sector, at 60 or 65 you have to retire. There's no other option. They will actually take you out of the job. But in UK you can continue to work. They will not, nobody can actually force you to come off. So people do have, I'm not sure much, but I am, at least in psychiatry, I've seen people who are in their 70s is still working as a psychiatrist. Their registration holds, their jobs hold as well. So the NHS will not actually kick you out like that for just being old.
There's a lot of social stigma attached as well.
Yeah,
I think we ourselves have a lot of social stigma attached. Oh, my friends, they have become consultant back home. I'm
yeah,
still a registrar. We have to understand that pathways in the UK and back home in our countries, they're extremely different. There is no comparison. You can't say that, oh, they've become a consultant. I will become consultant in the next 3 years. Pathways are different. The thresholds of making somebody consultant back in
mm,
Asian countries is quite lower. The
yeah.
threshold of making somebody a consultant is quite high, and it's very stricter in the UK. So I think we should also just
Have an
ignore
open
the
mind.
point.
Well, thank
Thank
you
you for
for
having.
good time. Thank you very much.
Thank you.